Well, it's 1:30 Eastern Standard Time. We'll get started. Welcome, everyone, for CDC's Preventive Medicine Grand Rounds for today, June 7th, 2023. My name is Mike Cherry. I'm from the Division of Workforce Development at CDC and CDC's Preventive Medicine Residency and Fellowship Program Director. We're joined today by Donna Grande, who's the Chief Executive Officer of the American College of Preventive Medicine, whose talk is titled Preventive Medicine, a Necessary Field of Medicine, who's going to be talking about what is a preventive medicine trained physician, why is it important and relevant in today's physician population, and really excited to have at Preventive Medicine Grand Rounds a talk from the American College of Preventive Medicine about preventive medicine. So I'm going to turn it over to Donna. We'll have the lecture, and then there'll be time for a question and answer at the end.
Excellent. Thank you so much, Mike. I really appreciate the kind introduction and the opportunity to be with not only your residents, but others across CDC that might have an interest in what preventive medicine is. So for the next few moments, I think we have about 45, 50 minutes at a minimum. I'm going to take you on a journey about what preventive medicine is and why it is important at this particular point in time in our nation's history. And I think hopefully you'll have an opportunity to gain some new knowledge. You're going to understand the competencies of preventive medicine physicians, the training requirements that are part of the journey for a preventive medicine physician. And then you'll gain knowledge about the roles and responsibilities of a preventive medicine physician. I'm going to share a couple of specific examples and some case studies and several examples that I hope will put some of the icing on the cake, so to speak, to really round out your understanding and awareness about what a preventive medicine physician is. Instead of disclosures, I'm actually going to offer up the American College of Preventive Medicine's value proposition. As CEO, I have a bias because preventive medicine physicians are, in fact, incredibly important. The ACPM is dedicated to the health and well-being of all Americans through the efforts of preventive medicine and public health physicians who share a passion for transforming healthcare systems and advancing individual and population health outcomes. That is the value proposition that embodies and embraces and actually reflects all that a preventive medicine physician does and what it's about. At the American College of Preventive Medicine, we actually create value for our members through ensuring that we have a high-performing team, that we offer networking opportunities for engaging our members, that we deliver high-quality products and services that help our physicians continue along their journey to maintain their certification, to continue all of their medical education requirements for their licensing requirements. We have user-friendly website and resources to also help them on their journey. And then as part of their professional development, we also offer opportunities to engage and to attend and to be part of various committees and special interest groups to sharpen the edge of a particular area or topic or function that they actually want to expand, enhance, step into, and to share more of. So this is the framework that we actually use here at the American College of Preventive Medicine to ensure that we are, in fact, rounding out the services that we offer and create value for preventive medicine physicians. Today, specifically, I'm going to share an overview of the residency training, what's required of it. I'm going to explain some areas of focus and some of the functions that preventive medicine physicians serve, some of the roles and responsibilities they have, and then opportunities to learn more, opportunities to see preventive medicine physicians in work, in various settings, as well as opportunities to share and showcase where you can go to learn more about what a preventive medicine physician does and to help explain it. So to take you on the journey, there are a lot of acronyms and a lot of organizations and a lot of stakeholders within the continuum of medical education. And the starting point was with the American Association of Medical Colleges. They're pretty much the front and center organization when it comes to the testing and the preparation for any undergraduate interested in submitting and applying to go to graduate school and to become a physician. And they also are the organization that manages the National Residency Match Program. That's when physicians complete their undergraduate education and then want to move into a residency program. They actually manage the match. Physicians have to apply for, they are interviewed at, and then they get matched into a program. And it's a big day of celebration when it comes to the actual match. The American College of Preventive Medicine manages the match program specifically for residents and residency programs for preventive medicine. We're on a different timeline. And the reason we're on a different timeline is because the residency requirements for preventive medicine requires a first-year clinical residency experience. And it often comes from family practice, pediatrics, oncology, or gynecology and obstetrics, and any other of the primary care fields predominantly. But the association, the AAMC, is one of our key colleagues and organizations that we work with closely to ensure that our residency programs are promoted in their match program as well. When you go into a AAMC website, you'll actually, they have so much data on all specialties, all practices, all residency programs, and they also maintain the numbers of how many active practicing physicians there are within a specific specialty area. What's highlighted here is preventive medicine. There are 6,500 preventive medicine physicians for a population, so 1 in 49,000 physician to patient ratio. But the 6,500, you'll see some of the other in an alpha order here anyways, that how many other active physicians there are in different specialties. Within pediatrics, there's over 60,000 active pediatricians. And when you look at psychiatry and others, there are some of the other numbers there. Also at the AAMC, you'll also learn a bit more about various highlights and percent by age. And when you see the percent of active physicians practicing over the age of 55, preventive medicine actually has the highest percentage of over 70% of the entire 6,500 that are actually active and practicing today. Another key interesting fact about preventive medicine, for those that might be on, you might be in your current residency program at CDC. Others of you might be interested in getting a secondary residency program or a second specialty. One of the key values from my point of view about preventive medicine, when you see the data here from the Medscape report, is that public health and preventive medicine has the lowest burnout when you look at the number of specialties. So emergency medicine has the highest burnout factor. Public health and preventive medicine is at the low end of this particular data set. And there are a number of reasons why that's the case. You might have some questions at the end of the program that you might want to ask about that. Once you go through your residency training, that is you have an undergraduate medical education, you have your graduate medical education, and then you actually, most physicians want to sit for their boards of their specialty. The American Board of Medical Specialties is the organization that actually establishes and unifies and brings forward the high standards for board certification. And that's another rung in the ladder of credentials that really demonstrate the competence and professionalism for a practicing physician. It enables healthcare organizations to select staff to really help them achieve their quality and safety goals. And it also is geared towards looking at assuring the public that physicians have the right certification, the right credentials, and the right standards so that they can actually be treated and cared for by a board certified physician, regardless of the specialty that they're seeking. So there are 24 certifying boards that are part of the ABMS, the American Board of Medical Specialty Societies. And one of those boards is the American Board of Preventive Medicine. And the American Board of Preventive Medicine, the number that I showed earlier, the 6,500 physicians, come from these different specialty areas. The three core areas of preventive medicine aerospace medicine, occupational and environmental medicine, and then general preventive medicine, public health. And that's where the American College of Preventive Medicine, our predominant and primary area focus is in the public health side of those three core specialties. Many of our members are also from aerospace and occupational medicine as well. The four subspecialties you'll see on the bottom of the slide: undersea and hyperbaric medicine, medical toxicology, addiction medicine, and then clinical informatics. Those are four of the subspecialties, as they're referred to, within the house of the Board of Preventive Medicine. So many of our physicians at the American College of Preventive Medicine and many preventive medicine physicians also have and are duly boarded, where they will have addiction medicine certification as well, or clinical informatics, or medical toxicology. The numbers of physicians for undersea hyperbaric are much smaller in numbers and less popular probably in the field of medicine. But that's to give you a sense of the family within the preventive medicine family. Now, board certification is at the top of the chart. The next rung down, going back now full circle, is the Accreditation Council for Graduate Medical Education. Now, the ACGME is the certifying body that accredits the residency programs. So your program there at the Centers for Disease Control is accredited by ACGME. The ACGME accredits all residency programs, and you'll see the numbers there, over 12,000. There are over 182 accredited specialties and subspecialties that are under the ACGME. There are over 800 sponsoring institutions with accredited programs, of which 70 are preventive medicine. So we are a small number among the entire 871 different institutions. And then there are over 153 residents at any one particular time within an ACGME accredited program. The ACGME establishes the milestones, and the milestones are the guide and the framework, the operational framework for the competencies that a preventive medicine resident and a preventive medicine physician will acquire over the course of their training program. Again, I said there's 1 year of clinical rotation, 1 year of a clinical residency program first, followed by 2 years of a preventive medicine residency program. During those 2 years within the preventive medicine residency program, the milestones that a physician needs to practice and the program requirements, to me, is one of the most critical parts of the experience. You can click on this QR code and go directly to the page with the URL that's outlined below, and you can actually get to the milestone document itself. The milestone document outlines the 6 key buckets of areas and skills and competencies, knowledge, and practice that each preventive medicine physician is required to obtain. So you'll see patient care requirements. You see the medical knowledge requirements. You'll see the systems-based practice requirements for patient safety and quality improvement, for systems navigation for patient and population-centered care, physician leadership in healthcare and community health systems. Again, those are competencies that are really important for preventive medicine physicians that are public health physicians that often practice in health departments and often serve as health commissioners within a state or local health department. They also serve as chief medical officers in industry. And again, physician leadership is an important aspect of that body of work. Practice-based learning and improvement, looking at evidence-based and informed practice. If you ask any preventive medicine physician, what's the #1 most important aspect of their work and their orientation and their competencies, it would be evidence-based science. Reflective practice, commitment to personal growth, disease outreach and surveillance systems, public health regulations, infectious diseases of public health significance, again, grounded in the public health aspects. And during their 2 years of their residency program, they are taking and getting the Masters of Public Health. So you will see an MD, MPH, and that demonstrates and shows not only the curriculum have they acquired, but they've also done rotations in health departments as well, applying directly the learning that they've acquired and the skills, and taking the skills and knowledge and applying it directly in a health department setting. Professionalism is a key part of any medical field and any specialty. And so the professional behavior and ethical principles are a key part of their training. Accountability, consciousness, self-awareness, help-seeking behaviors, as well as interpersonal communication skills. There are a number of our physicians that are trained in media advocacy and media and have become key spokespeople. And you'll see some of those examples towards the end of my talk today. The other part of the milestones is that there are exams and there are tests and there are assessments that are done throughout the course of their experience. And there are, within each of those competencies that I showed on the previous slide, there are different levels that they need to acquire and need to achieve during the course of their 2 years. So what you'll see here is just a sample, really looking at the pertinent policies and interventions for individual patient care. Might be as a level 1 completion and competency that they've acquired during their experience. Looking at how policies and plans are developed and implemented to support the health of individuals and communities, and so forth. So these are all parts of the milestone document. Now, this is during the residency training that they have to learn, acquire, and demonstrate their competencies in these areas. Once they graduate from their residency training program, they then need to sit for a board exam. And there are a number of review products and review courses that we offer even at the American College of Preventive Medicine to prepare any learner for sitting for the board exam. The board exam is offered twice a year, and there is a requirement. There has been a historical requirement for maintenance of certification, which requires certain projects, certain exams, certain continuing medical education to keep the certification in place. And the Board of Preventive Medicine is revising the way in which physicians within preventive medicine must maintain their certification. And that's all driven by the American Board of Medical Specialties that has also changed the way in which the requirements are established for ensuring the maintenance of certification. They've moved to a continuing certification program, which will be similar to a lifelong assessment process where you will have questions throughout the year that you must answer correctly. And then there's an aggregate number of outcomes over the course of 5 years to determine whether or not you need to sit for an exam or whether your certification is in fact eligible for renewal. So there are a number of hoops that physicians jump through and requirements that they must maintain to ensure that the highest standards of medical practice are in place. Within the residency programs, now this map actually shows both membership in the blue, and then the actual dots are where the residency programs are located. So within public health, general preventive medicine, we have 43 residency programs scattered for the most part throughout the latter and the edges of the country. You'll see the light blue in the middle of the rural areas, which there are some gaps in our country as far as standing up and or establishing residency programs. We remain quite hopeful that there will be some new residency programs established in some of these rural areas, because we believe strongly that preventive medicine physicians in their approach to both individual and community population health level care is really essential to be able to address many of the needs in rural America. The residency programs I mentioned, there are 70 within the entirety of preventive medicine, aerospace, occupational medicine, and 43 of which are within public health. Each of those residency programs, by the size of the red dot, you'll see vary in size. anywhere from some of our residency programs have 12 residents, 18 residents, some have 1 resident. So it really varies. So can you imagine being in a residency program where you're the only resident in preventive medicine, how isolating and lonely that would be? We create a cohort and a cadre of the preventive medicine residents so that there is this cohort and this networking and this solidarity, in essence, of experience, so that they can actually establish and develop and to become aware of their tribe, so to speak. The sad news, however, is that when you look at the residency programs and you look at preventive medicine residency slots, while there's 78 programs, there's also 683 slots available. The slots vary year to year because of the funding on one hand, but also because of the programs. If there's a program that has a couple of slots that closes because there's no funding, then the slots then go away. So 683 slots in 2020 to the 2021 school years. You'll see here on the far right of this slide, you can see some of the ranges and some of the evolution of the residency slots. The sad part, and for over a decade, probably several decades, the program slots available have only been filled by 50%. So 50% of preventive medicine public health slots are filled, and that's predominantly because of funding. Now, the funding for residency programs comes from the Department of Health and Human Services. Most of the GME, which is most of the graduate medical education funding, comes from the Centers for Medicare and Medicaid Services. A lot of the specialties have rotations, they have slots, they've been working with their teaching hospitals for decades, and they have kind of a turnkey situation where the residents in training will come in, they will go through their residency program, and they are seeing patients in hospitals and being covered by Medicare and Medicaid services dollars, the CMS dollars. Millions and billions of dollars are actually funding those slots and that work. For preventive medicine, we are an outlier, and our funding for preventive medicine residency programs comes from the Health Resources and Services Administration, HRSA. And so within the HRSA line item, there is a shared line item for both preventive medicine and the public health teaching programs. Now, the program funding for this, if we were to fund all 600 plus of those residency programs that I showed you on the last slide, and if we funded all the 300 plus specific slots for public health, we would need $52 million. It would be $52 million to be able to fund the entirety of the public health, general preventive medicine residency slots. We have been asking Congress for that amount for the past 3 years. What we have realized is about $7 million for preventive medicine, public health. The training centers, the public health training centers, have about $9 to $10 million in their portfolio. This year, they're asking for $12 million. With all the noise and all the information you read in the news and you've heard in the news, is that the debt ceiling discussions, the congressional budget approval process, this request for $52 million is probably dead on arrival. It probably will not be achieved. And we will be happy and hope for a cap that we would not lose any of this amount for any of the other cuts, and that will at least be able to achieve and to maintain the approximately $8 million in the line item. Now, these dollars do not represent the dollars towards the residency program there at the Centers for Disease Control. We are so very grateful that the Centers for Disease Control continues to fund, support, and to maintain the preventive medicine residency program within the CDC, because we also feel it's very important for the training, for the experience, and so many of the preventive medicine physicians that are part of the college here at ACPM have come through that residency program. and many of them are EIS officers. They've gone through the epidemiology intelligence service training within the CDC as well. So this is a big lift, as you can imagine. The organization, the American College of Preventive Medicine, is a very small organization. We have 14 staff, but small and mighty we are, as is the profession. And we are headquartered here in Washington, D.C., and we use our power, our voice, and our members' voice to advocate on Capitol Hill, not just for the residency programs, but also for other areas of importance and topics of importance, be it diabetes, hypertension, climate change, women's reproductive rights. We are there alongside of our public health colleagues and other medical specialty societies. The medical societies that we work with, as you can imagine, we're one of the more unique specialties because we work not only with all of the medical specialties, but we also work with all of the public health organizations and stakeholders. We are part of various coalitions. We align with and are supported by some CDC grants. We have colleagues and members at the FDA, at HRSA, at the OASH, the chief medical officer at the Office of the Assistant Secretary for Health is a preventive medicine trained physician. And we have physicians, even the chief of staff at the VA is a preventive medicine physician. So ACPM and preventive medicine covers the entire swath from physicians, public health, state and local government, also to federal government. Now, 5 years ago, when I joined ACPM, we received a grant from the Centers for Disease Control to really look at the value of preventive medicine. We called it the value of preventive medicine because we wanted to have a better understanding of how the assets and the competencies for preventive medicine physicians could actually be used and positioned and highlighted to fill the population health needs at hospitals. Many of the hospitals were jumping on the bandwagon, hiring population health specialists. And we felt strongly that the competencies for preventive medicine actually met the required needs for hospitals. So we conducted a study. It was a qualitative study, focus groups within C-suite physicians, key informant interviews within the hospital infrastructure. And absolutely, there was a correlation between the competencies for the training by preventive medicine physicians would absolutely fill the needs of the hospitals. And today, even with the safety net hospitals and all of the disparities of care and the inequities and the structural racism that we've seen within the medical engine, there's such a plausible and possible opportunity for preventive medicine physicians, not only to do rotations in safety net hospitals, but also to fill these roles, to truly look at the community assets, the community conditions, and to be able to identify policies, practices, and interventions community-wide that might actually look at the downstream effects of and the upstream impact, the downstream impacts and the upstream potential to turn the tide on some of the disease states that the hospitals are experiencing. Well, we learned a lot through this study and developed our own little infographic to help explain what are the competencies that are part of the training within a preventive medicine residency training program. And then what are the types of jobs and titles and functions that often surface within these competency areas that preventive medicine physicians serve, the roles they play, and the functions that they perform within the various settings. So you'll see there's health commissioners for state health departments, chief medical officers for large employer groups. Many of our physicians are branch chiefs or division directors or chief medical officers, even within federal agencies of the Department of Health and Human Services. But the titles and roles that you'll see here are built into an algorithm, even for our job center, so that we can, in fact, serve up jobs for residents as they come out of their training through our website so that they can find and secure positions that are going to meet their needs, fill their purpose and their career trajectory. Now, those of you that are training at CDC in the residency program, and you want to think about gaining perhaps another additional credential, there's also the opportunity that you can, in fact, gain the credential as a fellow of the American College of Preventive Medicine. That's another distinction that is part of a professional credential. And this is the class of 2023. You'll see here. There might be people that are familiar to you. Dr. Lisa Waddell, the Chief Medical Officer from the Centers for Disease Control Foundation. Dr. Clarence Lamb, State Senator for the state of Maryland. Also a residency program director at Johns Hopkins University. Dr. Brian Miller, who was just recently appointed to the MedPAC. So the range of our physicians is pretty vast. Dr. Chavinsky from a local health department is on here as well. So we have a number of different roles and positions that our physicians serve. And we've highlighted many of them, and I'll share a little bit more about them as well. So Dr. Ed Fess, he was the Chief Medical Officer for a health plan and a health system. Dr. Chris Purnell, you may have seen her on CNN, MSNBC as a key spokesperson for our Vaccine Confident campaign that I'll tell you about in a moment. She was the Chief Strategic Integration and Health Equity Officer at University Hospital in New Jersey. Dr. Maria Mora Pinzon has been in the academic setting, and she's at the University of Wisconsin. Dr. Tista Ghosh is an environmental medicine physician and practicing consultant. And as I mentioned, Dr. Lisa Waddell as the Chief Medical Officer at the CDC Foundation. So preventive medicine physicians serve a very diverse set of roles, responsibilities, and different functions across the health ecosystem. But I'll tell you, during the pandemic, we all know that both the healthcare system and the public health system both became a little fractured. The pandemic warts took its toll on all of us, everyone around the world, and it was an incredible journey. Trust was also shaken, and we felt strongly that we needed to amplify and bring forward a number of solutions and to strive to build in and to promote the best of what preventive medicine training, one of the key aspects of their training and competencies in emergency preparedness and response. So our board members and several of our residents, I teamed them up to work on 4 different papers to look at preparedness in public health, preparedness in the healthcare delivery and financing system, as well as in society. And each of the papers with an overview paper by our current president at the time, Dr. Stephanie Zaza, our immediate past president, Dr. Bob Carr, and the incoming president-elect, Dr. Tanette Krause-Wood. They wrote an overview on transforming the profession of preventive medicine. All 4 of these papers were published in our journal, the American Journal of Preventive Medicine, which hopefully you all know and have read and maybe are even subscribers to. But the papers on the impact of these 3 key areas each of them were published into the journal so that we could establish more awareness about the skills, competencies that physicians serve, not only for the field, but also for the media to know as a reference, as well as for policymakers to understand that there are some more skills and assets to bring to the table. We took these papers and we developed what I'll call lay reader papers, more content that was repurposed and repositioned to really help better understand what does a preventive medicine physician do, what is their role, and why are they important in these various domains and various aspects of the health ecosystem. So these are all resources on our website should you be interested in learning more. Now, the work at the American College of Preventive Medicine also follows the work of the competencies for the most part: diversity and inclusion, population health and lifestyle medicine, chronic disease prevention, our infectious disease prevention work around our COVID-19 grant work, and our work around working with health systems to identify better solutions on how to overcome and to mitigate the discrepancies and the disparities and the inequities in care. The cardiovascular disease prevention, we've been working with the Veterans Administration on virtual medicine and how we can use the virtual reality world to actually work with patients to help them become more aware of their behaviors and changing their behaviors to improve their health outcomes. And another interesting new area, we also are working on environmental exposures. Military environmental exposures are another area in which all physicians should be well-versed, knowledgeable, and understand how to assess their patients who come in from various exposures during their military work and performance. For the diversity, equity, and inclusion, we were part of a Health Equity Matters project sponsored by the ACPM and the Council for Medical Specialties Societies. And we did what many of the medical societies did, was to look back at our history to see whether or not there was any need for reconciliation or anything dark in our history that we needed to overcome and or address. And I will say I was quite pleased to see not only the leadership, the equity, the selection, the work of the college has been grounded in diversity and inclusion. I will also say that we established an award and a lecture in memory of Dr. Dan Blumenthal, who is a professor emeritus at Morehouse University in your backyard there in CDC, who was a stalwart leader in community health and disparities of care, as they were called at the time, and really took on the torch for social justice. And we have had 3 years now. This is our third year coming up with an award winner. The first was Dr. Marcella Nunes Smith. The second was Dr. Daniel Dawes. And then this year's is Dr. Kamara Jones, key leaders within the area of advancing health equity. We also developed our Vaccine Confident campaign, building on the strength of preventive medicine physicians and their work and their role in preventing death and disease. We deliberately selected and collected this brand with both the mask and the vaccine, recognizing once the pandemic was over, we were going to also still need to gain more confidence among not only physicians, but also among the public, that vaccines are the right preventable tool in our toolbox when it comes to health and healthcare. The Vaccine Confident campaign was developed at the time early in the pandemic when there were a lot of physicians that were skeptical about the speed and the rate of launch for the mRNA vaccine. And our vaccines, we surveyed our members, and 99% were confident that the science was accurate and this was the right thing to do. So the campaign was built around that. We received some additional funding from CDC to be able to take the campaign and to really go big and go large and go broadly with this. So we developed a campaign, we developed assets, we developed a way to engage our ambassadors and our members across the country to be spokespeople, to be part of the change that needed to happen so that we could in fact reach an audience that was very hard to reach, as well as reach an audience that had been excluded and or were hesitant for vaccines. I could go on, but I'm going to let the video speak for itself and share a bit about this campaign.
That shows us that this public health tool is not only safe, but it's effective. It is the greatest tool that we have.
For centuries, infectious diseases have threatened our way of life. With the widespread use of vaccines, we've been able to control or eradicate most of them.
We are vaccine confident, and you can be too. Doing our part to protect our community and to decrease and slow the transmission of this variant while we increase vaccination rates across the community.
Pfizer and the Moderna vaccines are very good at preventing disease, symptomatic disease related to the Delta or the Delta plus variant.
For centuries.
So the vaccine campaign was a incredible opportunity for us to really get out and to reach community members, as you saw in that overview. And we won a number of awards for the campaign, for the assets that we're so quite proud of. We worked with BRG Communications in our backyards here in Washington, D.C. on the campaign. And then we also recognize that it's important not only to build on and to continue the work to ensure that we can get patients back into and on schedule with their vaccines, but we also wanted to use the opportunity to create a new campaign to educate you, our audience on this call, and others about what is preventive medicine. So we have a new campaign that launched this last March at our annual conference. And this is where you will gain more information about what preventive medicine physician doctors do, who they are, and why this is important. The campaign was put together with a number of inputs, reactions, responses, and feedback from a diverse task force of committee members, senior leaders from our Board of Regents to residents in school, Dr. Boris Lushniak, the Dean of the School of Public Health, who sits on our board as well, and others. Just a real incredible cadre of committed preventive medicine physicians helped us develop this campaign with the overarching framework and message that the practice is essential because it's aimed at preventing disease, disability, and death by promoting health and well-being in patients, communities, and populations. That the profession is filled with physicians that are highly skilled clinicians who work upstream to improve population health through disease prevention and health promotion. And then also finally about ACPM, that we are the medical society serving board certified preventive medicine clinicians driven by a passion for prevention and improving health outcomes across a variety of industry and populations. There are various assets to the campaign to help educate health systems and health departments as to why they need a clinician trained in public health that's preventive medicine that can actually be part of their infrastructure, med students so that they can actually find and learn about preventive medicine before stumbling upon it after their first year clinicals or second year or frustration third year in surgery that we've had many of our residents come into after 3 years of surgery. Policymakers, because it's important for them to understand 2/3 of applicants into a residency program self-select according to the data, the AAMC, that they are non-white. If our country truly wants to diversify the face of medicine and the face of leadership in healthcare, Investing in preventive medicine would be a key opportunity and a key area to help amplify and to make that change happen. And then other healthcare providers and other specialties. As I showed earlier, there's a burnout factor. There are many physicians that are burnt out in their area of practice. This might be the next opportunity for a physician to become certified in a second specialty area. The materials and the assets, there are fact sheets that go into more details about what preventive medicine, how it's practiced, where it's practiced. There's an infographic that also explains where preventive medicine is practiced. If you're interested, these are all assets that are on our website. There are frequently asked questions many of you may have as far as what is preventive medicine, as I've talked about for almost an hour today. The social media toolkit for our members and others interested to actually showcase and to actually understand how to amplify the message of preventive medicine. There are interviews that have been conducted with our members at our annual conferences that share why they are a preventive medicine physician, why it's important from their perspective, and what they've gained from their experience as a preventive medicine physician. There are, as I mentioned, toolkits for students. And then I will have one final video for you to enjoy on what is preventive medicine.
Today, our nation's health faces new and existing challenges, with more opportunities to improve population health every day. One prescription can help change it all: preventive medicine. This is the essential medical specialty focused on preventing disease, disability, and death, and its practice all around us, in the doctor's office, the boardroom, the lab, the halls of government, and beyond. Preventive medicine bridges clinical care and community health, and its physicians are working every day to improve the lives of individuals, communities, and entire populations. These physicians work in health systems to address community health challenges, save costs, and deliver value-based care. They change policies to improve lives for the better. Partner with other physicians to provide new insights to improve patient care, and offer a career path for future leaders in healthcare and public health to leverage clinical skills for the whole population.
This public health tool is not only
The American College of Preventive Medicine equips physicians with the tools, resources, and knowledge they need to transform our healthcare system, building healthier communities, influencing policy for the better, improving care, preparing the future leaders of healthcare and public health.
we have to be able to question, to challenge our status quo.
We're doing our part to protect our community.
Addressing all determinants of health, commitment to changing the curriculum in public health.
This is preventive medicine.
So with that, it's the top of the hour and I am completed my presentation. So Dr. Cherry.
Thank you. Yes, great presentation. The presentation is now open for questions if people want to put their questions in the Q&A. I have some questions for you, but I'm going to go start with the chat. We have two questions. They're all both asking about the same thing, and it gets into medical schools and how to what's ACPM doing, a little bit more specific, people wanted to hear about really getting people's interest when they're in medical school, or maybe even in the curriculum of medical school. What is ACPM, their role, or your role in terms of trying to introduce it earlier? I know me personally, I didn't hear about it until residency. And I think there was a journal article that came out, was in October or November, looking at what led medical students or led people into the field of preventive medicine. And one of the biggest things was, is there a preventive medicine residency program associated with their medical school? And there's a lot of medical schools that don't have preventive medicine residency programs. So obviously, if they are there, it's an one method. But if there's not, what is ACPM doing to introduce it to medical schools that don't have a residency program nearby?
Sure, that's a great question, and that's part of the purpose of This is Preventive Medicine campaign, and specifically looking at med students and med schools So we have, right now, we're running some social geo practice, social media engagement with some of the assets. We have a campaign running at med schools right now, but we did a study probably 2-3 years ago, looking at undergraduate medical education and how could we integrate the core curriculum for preventive medicine and lifestyle medicine within the infrastructure. And I have to tell you, the document's available. It's on our website as well. But it's a complex engine, as you and many others know quite well, that what you hear from not just deans and academia in particular within med schools, that there's too much content already. And for adding anything else to the mix, you have to take something away. And you have these golden children the golden girls, golden children, whatever you want to call them, that are kind of the ivory stones that stay within the curriculum that are non-negotiables. And so, yes, we all believe strongly that if we could collectively change the curriculum of med schools, we'd be swimming upstream and establishing all physicians with a foundation and a base specifically on preventive medicine, preventive care, and understanding the importance of clinical preventive services. It's just a hard boulder to roll up the hill. But I'm happy to share that document. I can send it to you, Dr. Cherry, as well, if you'd like afterwards, and maybe circulate with your students or your trainees.
That'd be great. And maybe a little bit, related. We have a question about public health training, because preventive medicine is the only specialty where your education as an MD degree is not enough. You also have to have training in public health and curriculum and training in that. How do you foresee the future? Because it seems that there's more and more of these joint programs, MD, MPH programs. They're collaborating more. Do you see that changing? Will there be more public health for all medical students, or that it'll change the requirements such?
Yeah, I mean, I'm not going to say I'm a soothsayer or that I can read the crystal ball, but what I will say is that, yes, there are a number of combined programs. And I've asked the question myself to those combined programs, what's the difference? Even at Tulane University, for example, your own Dr. Deb Oury went to Tulane and went to a combined program, the MD MPH program. We have a residency program there as well in preventive medicine. So what's the difference? The key difference between the programs, as I understand and as I've learned, is that there's a residency rotation element that really provides the direct application in the health departments, that really applies directly the skills, knowledge, and expertise, and establishes the ability for a clinician that has been trained in family practice or another primary care that has that lens of direct patient care with a much broader lens of population health.
Yeah, similar for me too. I went to a combined MD MPH program, which I believe in that one journal article was the second most associated thing for people going into Prev Med is there an MPH program at their medical school? And it's very different than the residency, as I'm a graduate of the residency program and now a fellow of ACPM. So that's my shout out for the fellowship.
There you go. Thank you.
What opportunities does ACPM provide? We talk about rotations and electives and things for residents or even medical students to either come to ACPM or do policy. Is there any way that ACPM provides for residents and or medical students?
Yeah, we actually had from University of California, San Diego campus, we had a resident come in and do a health policy residency rotation with us. And my door is wide open for that. Absolutely. But we don't have funding to pay for the coverage of the salary and or their time. That individual fortunately had a sister that lived in town that he could live at her apartment and stay with us for a semester. So it worked out beautifully for us, beautifully for him. And it was incredible for the university, for the residency program as well. I would love to have that opportunity. So if there's anyone from CDC, almost like your public health associate program, we would love to have a health policy residency program here at ACPM. If I could pitch you for that, Mike, I am. But we would love to do that because what Dr. Tarek Salil experienced was just so profound. He was so blown away but it was really important to connect him with the Trust for America's Health, with Nadine Gracia, with Georges Benjamin at APHA, with all of the colleagues that we work with and work aside, as well as have the opportunity to go on the Hill with us to actually lobby for some of the residency training programs and the program funding that we need. So absolutely, we are all in for that. One of our public health associate, even that we've had now for the past 2 years, I had her work on a resolution for the upcoming House of Delegates meeting with the American Medical Association, really looking at prediabetes. There was not a prediabetes policy in the policy finder at AMA. With 96 million pre-diabetics in our country, shame on us in the healthcare that we aren't amplifying and helping educate all physicians on the need to actually focus in on pre-diabetics so that we can actually turn the tide on ensuring that it doesn't become full diabetes.
That's great. There's another question in the chat, which it may actually be for me. It says, is there a combination preventive medicine programs that are combined with EIS? You mentioned EIS, and just for I know a lot of people on the call know what EIS is, but for those who don't, the Epidemic Intelligence Service is a 2-year applied epidemiology training in place program. So working on epidemiology, where it's a postdoc program, and we do have physicians in the EIS program, where 2/3 are assigned to CDC headquarters and 1/3 are assigned to state, local, territorial, and tribal health departments. And there are a lot of people who, physicians, obviously, who then apply to the Preventive Medicine Residency Program at CDC, but also at other programs. We've had EIS alum go to Emory University's program, Morehouse's program, and others, and vice versa, where we've had a lot now of people who do the Preventive Medicine Residency Program first, and then do EIS after they've completed the Preventive Medicine Residency Program. We've had a lot of alumni from Tulane, Hopkins, most of the Preventive Medicine Residency programs. So there is a link between the two of them in some ways, a correlation, but not a direct program.
Yeah, and you know, Mike, this is, throughout my entire career, I have either worked with, for, had colleagues, friends, or supervisors that have been preventive medicine physicians. And when I think about some of the 20 years of my career was in tobacco control. Dr. Ron Davis, Dr. Tom Novotny, and Dr. Mike Fiore all went through the CDC EIS program and the PMR program. And all three of them, just their careers just absolutely blossomed into so many beautiful ways. Dr. Ron Davis became the president of the American Medical Association when he was working at the Henry Ford Health System after serving as the director of the Office on Smoking and Health there at CDC for a number of years. Unfortunately died too early from pancreatic cancer. Dr. Tom Novotny is still a member and fellow of the American College of Preventive Medicine, went on to an incredible career in tobacco control and worked for the IMF, the International Monetary Fund, and the World Health Organization. Dr. Mike Fiore up at Wisconsin, he has been just stalwart leader in tobacco cessation work and is one of the top researchers really looking at tobacco cessation. And so I could go on and on. Dr. Reed Tuckson was the health commissioner in DC, the executive vice president of United Healthcare. And so I could go on and on with the number of preventive medicine physicians that have just been incredible leaders and done such incredible work. Even yourself, Dr. Cherry, there at CDC. So for those that are listening and those on the phone, you're in the right place if you're in preventive medicine from my point of view.
Thank you. You're too kind. What do you think are the big challenges of preventive medicine? I know trying to get the word of what preventive medicine out there, but where do you see the field and the specialty in 5 years, 10 years, 20 years? And what's the possibilities for preventive medicine physicians?
Well, I think that the possibilities are endless for preventive medicine physicians, first and foremost, from my point of view, after knowing the field for over 30 years, I will say. So to me, the challenges are no different than they were probably 20, 30 years ago, as far as the pipeline, the funding, the awareness. I've heard this from so many of our members that were on the board 20 years ago. The challenges are the same, but what I'm hopeful for and what I'm most optimistic about is that we're making progress. we have the tools now, and we've been strategic in how we frame the video that you saw at the end of the talk, the positioning of the field, how we're actually being truly targeted with our messaging, and really going after where I believe are the right audiences. If we can raise the awareness within med students, medical universities, and with Congress in particular, and with colleagues even at CDC, don't eliminate your residency program at CDC. That would be such a mistake. You'd have a backlash of alumni probably coming out of the woodwork, because it is such an important part of the network, the trajectory, as well as the alliance to the Centers for Disease Control and Prevention, because it is part of our public health and clinical lens for so much of the work in health and healthcare.
And this is just a reminder to the audience, put your questions in the Q&A section. The chat does not work for this webinar or the microphone functions. So while we're waiting for any more questions, how has the field changed in terms of the percents of people going into occupational and aerospace and general preventive medicine? I know that there was a push to sort of create them as separate specialties recently, as compared to just a sort of a qualification. And again, my terminology may be all wrong here. And how are people changing in that?
Yeah, I meant to cover that. I think I talked about the ACGME, the Accreditation Council for Graduate Medical Education. So they voted to separate the 3 core specialties into individual milestones. So there was one set of milestones for preventive medicine as core, and then there were 3 individual subsets to the milestones and part of the board exam as well. So anyone from aerospace, occupational medicine, or public health, they all 3 would sit for the same exam, but they'd have a series of questions at the end that were very different and specific to that clinical track of the core specialty. So what ACGME did was they separated out the 3 core into 3 distinct milestones. There was a sense from our colleagues at ACOM that by separating, there would be greater visibility to bring more residents into occupational and environmental medicine over preventive medicine as the moniker. People may not understand what preventive medicine is, but they might understand occupational and environmental medicine. But from the match from this past year, the numbers didn't go up. So there wasn't this big flood of people like, aha, now I'm going to go into occupational medicine. That also may not be as clearly understood either as preventive medicine is or was or is. So we've been amplifying preventive medicine because preventive medicine, while a lot of physicians say they practice preventive medicine, right, because they want to focus on preventing disease and they want to address their patient's health and make sure that there is prevention in what they do to prevent disease and not just treat it. And so when you talk about preventive medicine with a capital P as the specialty, it's very different than the lowercase p of preventive medicine.
Our next question is about lifestyle medicine and obesity medicine. So lifestyle medicine is a subspecialty that a lot of people who are ACPM go into. Are there any plans to expand that or to go into the subspecialty of obesity medicine or other areas that ACPM could be going into?
Sure. So members of the American College of Preventive Medicine stood up and spun off and created the College of Lifestyle Medicine. And so we co-developed the Lifestyle Medicine Core Competency coursework. So that's a combined, owned, and produced and developed curriculum between the 2 organizations. So we work very closely with ACLM. They are our sister organization for all intents and purposes. They are not boarded. There is a board of lifestyle medicine, but it is not recognized by the ABMS. So I know they are searching for a home within specialties within ABMS for that added credential and that added stature. And that's a hard hill to climb as well, because there are so many requirements for the fellowships and the requirements to be actually a part of the ABMS as a specialty.
For some of the
Obesity, there is an obesity society, obesity medicine caucus on the House of Delegates, and we participate with them in that space. We, in our diabetes work, and I mentioned the resolution for prediabetes. I mean, clearly, when you look at the clinical preventive guidelines, when it comes to adolescent diabetes and others, it's more type 1 versus type 2. There is insufficient evidence for type 1 adolescent diabetes. But when you think about the number of and the growth of childhood obesity, it baffles me. You know, I come from 20 years of tobacco control, and if we had truly gone after the food manufacturing companies in the way that we went after tobacco control, when it comes to high fructose corn syrup and some of the other dietary standards, I mean, we've made a lot of progress, but there still is so much more to do and so much further to go to really turn the tide. There are already pre-established norms and behaviors of children, sedentary lifestyles, all the advertisements that they see, the sugar sweetened beverages, all of the cereals, you name it. There's a lot of food and dietary concerns, even the arguments with the USDA guidelines and having milk or chocolate milk banned from schools, right? Or are you going to put 2% milk back in schools? So there's a number of areas when it comes to obesity medicine. We feel strongly not to silo or to go down and to be a one chronic condition organization. We're looking at the holistic aspect, the entire population, the entire bucket of chronic conditions. How can we add voice and influence and interventions that are going to mitigate the overall disease onset? Because there are comorbidities for so many people. And we know through the pandemic, the data is only going to get worse for so many people who miss their clinical screenings. And there's going to be a lot of, I think, downstream implications, unfortunately.
And for some of those subspecialties of PrevMed, so we have clinical informatics and addiction medicine, which are relatively new, both of those specialties. How do the boards determine which board is responsible for the specialties or where they fall? Because they're in some parts, I mean, preventive medicine touches a lot of different fields, like you were talking about diabetes, which falls under endocrinology and internal medicine boards. So how does the American Board of Medical Specialty choose which goes where for the subspecialty?
That's outside of my lane of expertise, actually, Mike. I wish I knew, but that's a question for is it Richard Hawkins, I believe?
Mm-hmm. Yeah.
CEO of ABS. So you can, I'll ask him.
Okay. And then there's a question about ACPM's connection to the specialty of healthcare administration, management, and leadership, if you could talk about that.
Absolutely, happy to. And it's actually leadership and management. It's just, if you flipped it to it, we refer to it as HALM, HALM. Okay. So health administration leadership, it is a new specialty that's just been launched. ABMS, actually, we protested and we submitted some support to ABPM, the American Board of Preventive Medicine, to be the lead, since healthcare leadership is already one of the competency areas within the curriculum and the milestone document for preventive medicine. So ACEP, the American College of Emergency Physicians, their board, and the ABPM board, and I think there's one other. I could be mistaken, but I know at least emergency medicine and preventive medicine are the two key co-sponsors for that new certification. So we will absolutely be part of the development and part of the work that'll be going into the HALM program.
There's a little bit of a question about MD, like the education requirements, you can correct me if I'm wrong on this. The question was, do MD, MPH dual degree recipients have to take CEPH exams? Now, CEPH, we're talking about all these acronyms. CEPH is they accredit all the public health schools, the accredited public health schools. To become board certified in PrevMed, you need to take training in 5 different areas: epidemiology, biostatistics, environmental health, health policy and management, and health education. There is a CPH exam for certification in public health, which isn't required for being board certified in PrevMed. So that's the only thing, and I'm just going to quickly address that question.
They don't get the full MPH program. I mean, they get the degree, the MPH degree, as part of their training and curriculum. I'm not familiar with the certification aspect.
There's a question about interest groups that members can join. You mentioned that, and they didn't see it on the website. They only saw committees that you can volunteer in, but how can one find out more about the interest groups to join?
Sure. Probably in our newsletter next week, actually, will be posted, because we have a special interest group on pharmacovigilance, one on global health, and one that just came forward earlier this week, a request for maternal health. So with all of the changes in reproductive health, there was a request, and the disparities, clearly we have so much in that space to discuss. But yes, there are 3. So I would suggest, if you're interested, to please send an email to either membership at acpm.org or into info@acpm.org, into those 2 links that you'll see on the website, and ask the question, and then we'll make sure we capture the name, and when those launch, we'll make sure to get you plugged into those.
Historically, there's been the specialty of general preventive medicine and public health were 2 separate specialties. One was a little bit more clinical, one was a little bit more public health government focused, and then they merged, and this must have been a long time ago, into one specialty. And it seems that occasionally over the years, PrevMed has sort of gone back and forth, maybe trying to find that right balance between clinical and government, or sort of that applied public health type thing. And it seems to change back and forth. Sometimes ACGME wants different things. They want it a little bit more clinical in some ways, or a little bit more public health, and you're required to do 2 months of clinical and 2 months of government public health during a residency program. Where do you see that balance going over the years in the future, with more or less clinical, more or less government public health?
Yeah, that's a great question. I don't sit on the committee that actually makes those determinations, but there is a large committee of prepared preventive medicine physicians that are part of the committees that takes a look at the milestones. The new milestones are supposed to be launched next month. I've not seen them, so there might be some nuances there. But what I will say is that each residency program takes a look at the milestones and interprets them for their program. There are some residency programs, you asked earlier about the MD-MPH combined programs. There's actually a push, and I think if I was to look at the crystal ball 10, 20 years from now, maybe, there might be more family medicine and preventive medicine dual programs. So similar to the program at Stony Brook up in New York, there's that duality where you're actually family practice and then preventive medicine. So it's a longer duration of time that you're in residency training, but you actually walk away with the ability to be boarded in both family practice and in preventive medicine, which actually meets the needs of many of those members, and many members that want to have that balance. The clinical aspect, on one hand, they might see patients, and most of our members, they do still see patients 1 day a week. So they still get that clinical hit of, that plays to that pulse of their desire to actually see patients one-on-one. And predominantly those are the ones that are also dual certified and boarded in lifestyle medicine also, because they want to really help patients better understand their own lifestyle choices and how to change and turn the tide on their diabetes or in their lifestyle, and really look at some of those conditions that a patient shows up with. So but I think family practice peds, there are a number of our physicians that are also duly boarded in pediatrics. So it's really, you know, it's such an individual choice. And because of the diversity of the field and how people are practicing medicine, you know, we have the chief medical officer for Share Care, right?
Mhm.
It's all data analysis. There's a lot of the data interpretation and the interventions there. It's really population based. It's not necessarily one patient at a time. I don't know if I answered your question though.
Yeah, no, that did a great job. We have a question about other healthcare providers. So the ACPM primarily focuses on board certified preventive medicine physicians. Is there any, how does ACPM collaborate with nurse practitioners and advanced practice nurses and others in the field of preventive medicine? And are there certifications for nurses or others to become board certified or go through a training in preventive medicine?
It's a great question. It's a question that our board's actually looking at now through our strategy committee, and that has to do with expanding beyond a physician-only organization. Is there value, and is there do we have the capacity to expand and to work with and invite in and create a certification for preventive medicine for nurses and other clinicians? I came from the American Nurses Association, and I care deeply about nurses. I think they are the angels on earth. You know, every nurse has wings, I will tell you that. And so if there is an opportunity for us to meet the needs of the nursing field with either the courses we offer, the content we have, and meeting their needs, I would be all for that. That's Donna speaking.
Well, I do agree that the value of having, it's really a team effort, and with preventive medicine having all involved.
Absolutely.
Is the how do ACPM, ACGME, and ABPM interact or collaborate? So you have three different kind of organizations, all have different roles and sort of accreditation and board certification and things. How do you all collaborate together or interact?
Sure. So ABPM, right? We have stakeholder meetings, so we meet regularly with ABPM. We've had conversations about the move from maintenance to certification into this lifelong learning assessment. There will be remediation programs. They're trying to find a new name for what that future state of continuing certification will look like. So if there is, for example, if somebody takes these new exams and these new tests, these regular tests, and scores low on them, by the second or third year, they might need to take a remediation course. So we'll get the data on where the performance indicators are to really look at how might we develop the right courses to meet the needs and the gaps in the learning that some of the learners have, so we can meet those needs. So those are discussions that happen. There's an element of a firewall between the two, as you can imagine. So there are those that work on the exam test writing that we are not involved at all as the college, but some of our members might be part of those exam writing teams. But there's a confidentiality and the proper firewall to meet the compliance requirements when it comes to ABPM. ACGME, they co-launched the Equity Matters program as an example with the Council for Medical Specialty Societies. We are a member of the CMSS, and so we ACPM were one of the 18 specialty organizations that stood up and said, yes, pick us. We want to be part of this pilot. And it was an incredible journey for 18 months that we worked with our colleagues at ACGME and with with CMSS. And so ACGME, they come to our annual conference and present any changes to the milestones, and they talk about residency training. They present the aggregate data and the specific data across all specialties, so we can see how are we faring against other specialties as far as the number of residency programs starting up, closing, and just some of the shifts and trends. So those are just some examples of how we work together with those two other organizations.
There's a question about the National Board of Public Health Examiners. And so they do board exams for non-physicians, and sort of bringing up some of the topics we brought about. Do you know if there's any collaboration that ACPM does with them, or that American Board of Preventive Medicine, who does the exams for physicians, collaborate with them, or are they kind of done in silos, the exams?
That's a great question, and I don't have an answer for that. I know we work with the Public Health Accreditation Board, but more collegially, but not necessarily in a specific project. We're hoping we'll be able to work more closely with them on the new workforce funding, so that we can get more education and information about preventive medicine as part of that workforce rebuild for the public health infrastructure across the country. But I'm not sure about the NBPHE.
Great. Well, that is all the questions that sort of came in. There was a lot, so thank you. That happened. I want to thank you, Donna, for presenting, for a lively discussion with a lot of the questions. I want to thank my audience and our audience who came to watch. Please join us for our next Preventive Medicine Residency Grand Rounds, with the information will be sent out through email. Thank you, everyone, for attending. And this ends today's Preventive Medicine Grand Rounds.
Yeah, thank you for the opportunity. Bye-bye.